So today our goal with Spine Camp is to just better prepare you for your upcoming spine surgery. We understand that having surgery is scary and that it does elicit anxiety for a lot of our patients. And we also understand that the scary thing about having surgery is really just the fear of the unknown. So what we want to do is to help alleviate some of those fears by providing you with as much information as possible to help better prepare you for the weeks and days before surgery. Also, we're going to discuss what to expect on the day of surgery and then even into discharge in those days after. So what we want you to understand is that you do play a large role in a positive outcome for your surgery. And so it is very important for you to understand that role so that we can better prepare you for a successful surgery. Attending pre-op is definitely one of those items that we need you to do. Pre-op is a clinic appointment that basically does a full body systems assessment. Once we do that assessment will identify risks of you having surgery. And then hopefully during that clinic appointment, we will then develop a plan of care to either eliminate those risks or decrease those risks for you prior to having surgery. Smoking cessation is a hot ticket item for all of our spine surgeons. Many of our surgeons will not even schedule our patients for surgery unless they are nicotine free. If you're one of those patients, making it to this point, you've probably already been through a pretty strict no smoking period of 4 to 6 weeks. Typically speaking, we do want our patients to be at least 4 to 6 weeks free of nicotine prior to even scheduling them for any of our surgeries. With that in mind, we all know that smoking in itself is just unhealthy and an unhealthy lifestyle choice. And so how it affects you in your surgery is that it increases your heart rate and your blood pressure, which then does increase stress on your body. And we already know that simply having surgery is an increased stress on our bodies. It increases your risk of blood clots. And again, surgery already poses you as an increased risk for blood clots. So we certainly don't want that to be further increased. It narrows arteries and that reduces that oxygen-rich blood that we need to have optimized healing. And then it also increases your risk of complications, respiratory complications during your surgery. We sedate all of our patients for surgery, and when you're under sedation, we do use a machine to help patients breathe during the case. A lot of our patients that are smokers, unfortunately, have a little bit more difficulty getting off of that respirator once we are ready to have you come out of sedation. And so that also becomes an increased risk that we do not like to take. So within this program, what I'd like to do is really to not leave any situation unknown for our patients. And so I do like to inform you of different ways that are very unexpected for some of our patients that could potentially lead you to a cancellation on the day of your surgery. Smoking cessation, like I said, is a very important topic for our surgeons, and it's very much a zero tolerance once they've identified you as one of those patients that would require to be nicotine free or smoke free prior to your surgery. So for those patients who have been instructed to stop smoking prior to to your surgery, on the day of surgery when you arrive, we do draw labs, and those labs will actually contain nicotine levels. And so unfortunately, I have seen all too many times when patients come in and they have done the hard work of quitting smoking for the 4 to 6 weeks prior to being scheduled, and then had a relapse and continue to smoke once they've been scheduled for surgery, come in that day of surgery and labs are drawn and we have high nicotine levels or any nicotine levels in our blood, and they are canceled on the day of surgery. It's very disappointing. And so what I want our patients to know is all situations that can happen, so really that nothing comes up unexpectedly, and that's why I bring that information up. As far as diet and hydration, we know that just lays a healthy foundation anyway in just everyday life. Having improved diet prior to your surgery, optimizes healing. But in the immediate sense of how it plays in your surgery day is, we do have surgeries that start at 7, and usually we tell our patients to check in 2 hours prior to their start of surgery. That means that some patients will be checking in at 5 o'clock in the morning. Other side to that is that we have surgeries that continue on until 3 and 4 o'clock in the afternoon, which means there are patients checking in for surgery also at 1 and 2 o'clock in the afternoon. Again, the reason why I mentioned this information is because you will be instructed to not eat after a certain time, and that time typically is 11 o'clock 11 o'clock at night the day before your surgery. So if you're a 5 o'clock check-in time, that may not affect you as much as far as feeling hungry prior to the start of your surgery. However, if you are that 1 and 2 o'clock check-in time, that time could be a little bit more frustrating for those who may be a little bit more hungry. So how diet plays in that is we usually say, number one, if you are an early dinner eater, if you like to eat dinner around 4 and 5 o'clock, I would say go ahead and eat your dinner at your regular time. And then also reserve a time for about an hour prior to the stoppage of eating that we tell you, your time of stoppage, and maybe an hour before that, and make sure that you eat something that is very high in protein and high in fiber. Those two items will help keep you satisfied for a lot longer. So if you do happen to be that person that has to check in at 1 or 2 o'clock in the afternoon, then that frustration level won't be as much if that last meal is fortified with increased protein and increased fiber. Hydration, if we place an IV in all of our patients upon arrival to their day of surgery. And typically speaking, that IV is just a lot easier to get in if our patients are hydrated. Usually you can drink a lot longer than you can eat, so be mindful of that. And usually how I tell patients to stay hydrated is, typically speaking, the liquids that they allow you to drink the day before surgery or the night before surgery are clear liquids. And so clear liquids really involves anything that you can see through. So of course that means water. Gatorade is another example. You can have apple juice. You can have tea and coffee, no creamer. So anything that is easily seen through is considered a clear liquid. And so how I tell patients to make sure that they just stay hydrated, besides just boosting drinking throughout the day, is at night, just keep something at bedside that you do like to drink, whether it be water or Gatorade, and then just have that at your bedside table through the night. And, I don't encourage patients to purposely wake up through the night, because we all understand that having good sleep also is very important before surgery. But everybody inevitably always wakes up kind of throughout the night for any one reason or another. So if you do happen to wake up through the night, then you'll have easy access to that drink, and just be very conscious of, boosting your hydration and drinking that through the night if it is within that time frame that you're allowed to drink. And then having and arranging help at home. All of our surgeons are going to recommend at least having someone available in your home for assistance in that first 24 to 48 hours. And so you aren't going to need a whole lot of assistance, but we know that you're going to be not able to do your normal activities of daily living to the extent of what you were doing prior to your surgery. So you will be able to get up and use the bathroom and get up and get a drink, but as far as preparing a full meal or doing any kind of household chores will be things that you'll progressively work yourself towards into a full day worth of being able to accomplish those kind of goals. But for now, you're going to have someone there that can help you do those activities of daily living, so you can kind of be able to work yourself into doing a full days of activities like that. Also, it's really important to know that, you know, we will have you do dressing changes. A lot of your dressings are going to be located on your back, and so that's going to be very difficult for many or all of our patients to be able to address those wound issues on their own. So having that help available to be able to change those dressings, and even getting a good look for us to make sure that the incision looks well and that there isn't anything that needs to be addressed in regards to your incision, is helpful as well. So home setup. You know, the weeks and days before surgery, just taking a good evaluation of things that are going on in your house that could potentially pose a risk to you for a fall. So what we want to do is eliminate or reduce those as much as possible in the weeks and days before surgery. So if that means we have rugs that have edges that like to pull up every now and then, maybe to remove that rug for that time. Any clutter that might be in the way of traffic, high traffic areas in the house that you could potentially trip over, we want to reduce that. Anything that would pose as a fall risk for you in the immediate post-op phase of going home. So we can certainly do that to begin with. What I also tell our patients to do is really just taking one full day, grabbing a notebook, and then just going through a day in the life of a normal day for you. So starting from the time that you wake up and taking really close notice of those things that might be a little difficult for you to do now. Knowing that anything that is difficult now is probably also going to be difficult when you come home after surgery. And that way we can be prepared for those items that need to be addressed during your stay with us. And that way we can make sure that you're going home and able to maneuver around your daily life without much needing assistance. So if that means waking up in the morning and you realize that getting out of your bed is very difficult because it's a little bit higher off the ground, make note of that. If you have a toilet or a favorite chair that seems to be really difficult for you to push yourself out of and getting yourself in and out of that area, make note of that. If you have difficulty, maybe you have a tub shower combination as your only source of providing a shower, then you might address that it's difficult to step in and out of the bathtub. And so making note of that. And so that way you bring that list to us. Physical therapy will evaluate how well you're doing, and maybe at that time address any of those needs and be able to help you safely maneuver around those items in your house once you get home. So prior to surgery, you will be receiving a pre-op phone call. That phone call is actually going to be made by a nurse that works in the pre-op area. So that nurse could be actually the nurse that would be taking care of you on the day of surgery that you check in, which is wonderful information to know, because I always tell patients that that could be your last line of defense for any last minute questions that you might have, and they would be a great resource for that. That pre-op phone call is really going to consist of when you are to check in. So that is going to be your final check-in time that you'll need to come in for. The pre-op phone call is also usually made the business day before your surgery. So obviously, if your surgery is held on Friday, then that phone call would be made on Thursday. If your surgery is on a Monday, then it would be made on that Friday. We do honor holidays at the university and the Missouri Orthopedic Institute, so we would also not make phone calls on those holidays that are observed for both areas. That phone call also is going to include a review of things that they went over with you in the pre-op clinic appointment. So all of those medications that they don't want you to take, they will make sure that they review those medications that they do and do not want you to take. At that point, we're also going to make sure that you have help lined up. We'll also go over any questions of the surgical prep that we require you to do the day before and the day of surgery. And so all of those will be issues that they will cover during that phone call. So one of the things that I want our patients to do during that phone call as well, if they haven't already done it, is just to do a quick assessment of their skin integrity. And the reason why for this is because, you know, we're all out there kind of doing yard work and living life. And so sometimes that would have us have nicks and cuts and scrapes on our body that we might be doctoring up on our own. I mention this because we have had patients that actually do come in for surgery and have been doctoring up maybe a wound on their leg that they sustained while doing yard work. And it looked suspicious enough that it might be infected that our surgeons have canceled surgeries due to that. So again, don't want you to be surprised by any situation that could come up. And so that's why I always say, go ahead and take a quick look at that phone call time and just make sure, even if it's nowhere near your surgical site, if it looks suspicious of an infection, if we've got some redness in that area, some foul colored drainage, you know, it feels kind of warm to touch. Those are all good reasons to get attention from your surgical team or to make note of that during that pre-op phone call with that nurse. If we need to, at that point, address it with antibiotics or just to make sure that you keep monitoring it for us so that way we don't incur that risk, extra risk of infection on the day of surgery. So here we go over a little bit of anatomy. I won't go into too much detail when it comes to anatomy. What I do want you to know is the main reason why we ever do spine surgery is because we have some sort of impingement to a nerve. So we know we have nerves, spinal column, our spinal cord kind of goes through right here. And we also have nerves that come out the left and right of the vertebral body too. And so anything that compresses against that nerve is usually what causes you to have the symptoms that you're currently having that is requiring you to have surgery. So all of the fancy words that you hear in regards to the type of surgery you're having is really just anatomy. It is telling us the part of the vertebrae that we might have to either remove or support to take the pressure off of that nerve that is causing you your pain and discomfort and weakness. And so, for example, if you are having a microdiscectomy, this is our disc, and microdiscectomy just simply means maybe you've got a little protrusion of your disc that's bulging, and it is compressing against that nerve that runs down, or the spinal cord that runs down the center here. And so microdiscectomy is simply removing the disc that is protruding into that nerve. If you want to have any more details about specifically what your surgery is, we do have not all of the surgeries, but definitely a good list of surgeries that we do on page 6 and 7 of your spine book if you want to review that. So pain is definitely a big issue with our patients, and we understand that everybody has a fear of having discomfort after surgery. And what we're here to tell you is, unfortunately, pain is definitely common, or not pain, but discomfort is still very common after surgery. However, what we want you to know is the structural or the mechanical reason of why you're having the pain has been fixed. So the reason why we go to surgery, again, is we want to eliminate whatever is compressing that nerve that is causing your symptoms. When you are finished with surgery, that mechanical reason, that structural reason that is causing you to have that discomfort is gone. However, that is being replaced by the incisional discomfort that you're going to have, because we do open up the skin, and then we do manipulate some of those areas to get into the spot that we need to do surgery. So you'll have that kind of incisional pain that is also going to be sensitive right after surgery. But the good thing is we know that that does go away with time. And so we also want you to know that there's more involved with pain than just what is physically causing that pain. We all know that many of our spine patients have been dealing with pain for a very, very long time, getting to this point of being able to have surgery. And so that really just means that our nervous system is kind of accustomed to having very sensitized pain receptors. And there are some things that definitely contribute to having increased pain after surgery. And like I said, mechanically and physically, we've gotten rid of that pain, but we also know that there's other things that can cause increased pain, such as having the stress of being in a hospital, being in an unknown environment, unknown schedule. We also know that people have animals at home, and maybe they're concerned that now I'm here in the hospital for X amount of time, and who's going to be able to take care of my animals. And so we understand that that also contributes, that stress can also contribute to heightened pain. And then just making you aware of that situation hopefully can help you have a better understanding of underlying reasons of why people have pain, and then hopefully to be able to reduce that pain by decreasing those stressors for you. Another thing that we recommend for decreasing pain is, it sounds like it's the opposite thing you would do to help with pain, but is moving frequently. After surgery, our bodies start to heal, and they do, the muscles at that point become very tight. And so the more you lie still, the more stiffness you'll have, which then can increase your pain once you decide to get up. And so that's why our goal after surgery is to mobilize our patients on the day of surgery. And then thereafter, we want you to have some sort of movement about every 30 to 60 minutes after that. So we're pretty strict on moving, and we understand that that helps loosen up the body. It does actually help decrease our pain, and the more everybody understands that, the better off our recovery process will be. So what I also want you to know is that we do have a resource in our pharmacy. The book is a very quick read. It's called My Nerves Are Having Back Surgery. It is just really a good book that kind of goes over the mechanisms behind how our nervous system gets a little bit overexcitable or a little sensitive, and then how we can reduce the pain, kind of knowing this information. I think it's $5 in our pharmacy. It may even be a quick enough read that you could stop by, pick it up, read it, and not even have to purchase it, but it is a good resource if you want more information about that.
Here at the University of Missouri in the Spine Center, you and your surgeon may be planning a spine surgery. Patients who undergo spine surgery can experience several types of pain. They can experience pain from the irritation of nerves, muscle spasm pain, general inflammation, and the soreness of having muscles and bones cut. Post-operative medications target each of these. A medication like gabapentin may be used for irritated nerve pain. A muscle relaxer may be used for muscle spasm pain. NSAIDs, or non-steroidal anti-inflammatory drugs, may be used for the inflammation. And narcotics may be used for the generalized soreness of the surgery. The pain profile typically changes in the days following surgery. We adjust medications accordingly. It's possible that you may go home with a prescription for each of these medications. Of these, narcotics carry the most downside risk. Pain is usually worst in the days following your surgery, and after a few days, it's recommended to start weaning yourself off the narcotic pain medication and using alternative methods to help reduce pain. Alternative methods include walking, taking Tylenol or ibuprofen, if approved by your physician, using heat or ice or a combination of these in the area of your surgery. Common side effects of taking narcotic pain medication can include nausea, vomiting, breathing issues, constipation, and inability to achieve restful sleep. Other risk factors include addiction, dependence, and misuse. These risk factors increase the longer you take narcotic medications, especially greater than approximately 5 to 7 days. Long-term use can also increase pain sensitivity and alter your pain perception, making it difficult to manage pain. As a surgical patient at the University of Missouri, our clinical team works to ensure a pain management approach specific to your recovery. While you are in surgery, anesthesia gives a combination of these drugs to keep you comfortable. After surgery, you may be discharged with 5 days worth of narcotics, but a greater duration of the other medications since they are safer to take longer term. Beyond that time, you must call to request an additional prescription. This may require an earlier visit or a phone call to review the necessity, depending on your surgeon's preference. Our American Academy of Orthopedic Surgeons recommends discharge prescriptions of no longer than 5 days of narcotics. There is a good reason for this, and we abide by this guideline. If you have questions regarding your pain or use of medications, please refer to the contact sheet within your discharge instructions to contact your physician's team.
All right, so now that we have kind of mentally prepared for surgery, what we're going to discuss now is just how you can physically get prepared for surgery. So what we want you to do here is really just to think about how you currently move. So if that means how you hold yourself in everyday posture, positioning, that's what we want to take close notice of in this section. So what we want to do is get you established with good habits now so that it's just easier for you after surgery. So in page 13 of your book, it kind of goes over how to properly sit in a chair. And so most of us, we tend to posture in this sense. It's kind of painful for a lot of our spine patients to be able to keep themselves erect with their shoulders back and spine straight. We understand that that's difficult, but this is the preferred way to hold ourselves in having our spine positioned in, and it's called a neutral spine. And what we want to do is really protect this curvature that we have in our lower back to keep ourselves in that neutral spine. I understand that even after surgery, it's going to be a little bit more difficult to be able to sustain yourself in this position. And so we do have kind of tricks to be able to keep it in the forefront of our mind and also to be able to maintain that posture without a lot of work on your part. So what we usually recommend, besides keeping your shoulders back and upright and sitting straight, if it's difficult to keep that curvature in our spine, what we usually recommend patients to do is if you can find like a small pillow or roll up a bath towel or a hand towel. And what you'll do is once you sit in your chair, in that posture with your hips back and all the way back into the chair and your shoulders erect and back and your spine in that nice neutral position, is once we get to that position where we are kind of getting fatigued by doing that, we can then take that hand towel or rolled up hand towel or that pillow and then just kind of fit it in that curvature of our back and lay back in our chair, and then it will help kind of keep you in that neutral spine position without a lot of extra work on your part. Of course, you will have to be aware and cognizant of keeping that posture, but it will be a lot less work if we are able to have that support provided by that pillow or that rolled up towel. We do also have exercises that we want to help with strength and flexibility of both your hips, your abs, and your legs. And reason for that is the more we strengthen those legs, the less that you'll rely on using your arms for getting in and out of chairs, in and out of bed. And then that makes it a lot easier for you to be able to maneuver around those positions. And so we do have a lot of exercises that concentrate on kind of the legs and how to strengthen those. So just in 8 and 9 of your spine book, again, they'll go over those exercises. We would recommend trying to do those in the days and weeks before your surgery. Activating our abs is another way to kind of help prepare for surgery. Our abs get neglected a lot of the times. And so activating it isn't making you go do crunches or sit-ups or anything like that. It's simply just finding your abs, being aware of them, engaging them, and then releasing them, and just being able to use and be aware of them just sitting in a chair. So what we want you to do really is if you want to prepare like you're getting punched in the stomach. And so what you do is you'll kind of tighten up your abs and pull your belly button away from your pant line. And so you kind of, in that sitting upright position, you'll contract those abs and bring them in and hold it for 5 to 10 seconds and release. Of course, none of this should be exhausting. And so you definitely want to be able to still breathe normally when you're doing these exercises. So definitely don't hold your breath during these exercises. Flexibility is another issue that we want you to work on. And reason for that is if we are tight in our hamstrings or in our quads, in our thighs, what happens is if those muscles are tight, then you begin to then draw those muscles in your spine. It exaggerates those muscles in your spine and it pulls on them, so then it can pull your back out of kind of proper alignment. So if you have that flexibility in your hamstrings, and so if we give you a few exercises, I believe in the book, that will help increase that flexibility in those areas, it will definitely have lessen that pressure on your spine after surgery. So here we go over log rolling. So many of you honestly probably already use this procedure to get in and out of bed. For the majority of both our cervical patients and our lumbar patients, this is probably by far one of the easiest, less pain-inducing ways of getting out of bed. And so you may be doing this on your own and not even knowing that this is something that we want you working on. But how we want you to get out of bed, we'll use this as first line of defense. It is not the only way to get in and out of bed. So if it doesn't work for you, we can certainly find another way that works better. But this will be our first line of defense. So if you're more familiarized with how we do this now, then it will be a lot easier once we get you out of bed for the first time after surgery. So what we really want you to know is once you're in a lying position, if you're going to be coming out of the bed on this side, you'll raise your opposite leg up. And this will be kind of your weight and your pendulum to kind of help get you rolled over. And what we want you to really to keep track of is that we want to make sure that we roll. It's called log rolling because we want to roll as one single unit. So nothing goes before the other. So we want the shoulders and the hips to move at the same time, like a log. So once we get that leg bent up on the opposite, the opposite side of the direction you're going, so meaning if you're coming out of the right side of the bed, you're going to bend up your left leg. So once you get to that point, both the shoulders and the hips come together at the same time, and then you'll be lying on your side. So from this point on, we will start to put the feet off the side of the bed, but at the same time, you will put this arm and start to work it into a fashion where you can push yourself up. Now, this has to be a very fluid motion for it to occur without any discomfort. So a lot of times people get into a position where they get stuck, where they drop their legs down all the way, and now they're kind of in this crooked, my upper body is still on the bed and my lower body is off the side of the bed. That we're trying to avoid that. So what we want to do is make sure it's one nice fluid motion. As the legs start to come down, that arm will then go underneath the body and we'll use the legs as a weight in a pendulum to where once the legs start to swing down, we'll use that momentum and you get our upper body up. And at that point, we should be in a sitting position. We will do the complete opposite when you're getting into bed. So once you're sitting on the side of the bed, we want to make sure that we stay parallel to the side of the bed. This is where people usually get stuck at the most. And so when we get to the point where we start to put our legs up, then our arms should be helping us draw down to the side of the bed. And when I mean side, we want to stay parallel to the bed. A lot of times what happens is it gets kind of painful when you get halfway there and people then instead of laying on the side of the bed, they end up going diagonal in the bed and falling back onto their back to the opposite corner of the bed. And that becomes a problem because then it requires a lot more maneuvering on your part to get yourself back centered into the bed. So a slow fluid process. Again, as the legs start to raise up, this arm should be sliding out parallel to the bed. Once we get completely down where the legs are up and you're off to the side, then at that point, shoulders and hips all together will roll back onto our backs and you will be now centered in the center of the bed. So this is where we kind of go over the vocabulary section of Spine Camp. And what I really want you to get out of the slide is really the fact that the day of surgery and post-op day 0 mean the exact same thing. So post-op, meaning after surgery, day 0 means day of surgery. It seems like I don't have to go over this information, but it actually has caused a lot of confusion for some of our patients because sometimes we forget that the language we use in the hospital is easy for us to understand, but we forget that that's not language that you hear as a patient every day. And so we have had many physicians that will come into the hospital and talk to their families and say, oh, they're doing great. We expect you to leave on post-op day 1. If you did not know that there was a day 0, then you would expect to be leaving on the same day. And many patients have already been told their length of stay maybe at that clinic appointment when they scheduled surgery and already know or had been thinking that they were staying a day, prepared for that, and then then maybe think that the physician is telling them they're going home on the same day, which can be a little anxiety provoking. So this is really just to kind of alleviate that miscommunication between providers and patients and even nursing and patients to ease those worries. But I do want you to know we are trending now more towards same day surgeries. Same day simply means that our patients will go home before 23 hours of having their surgery. So theoretically meaning you would go home the same day, but if it's your surgery is a late surgery, 3 or 4 o'clock in the afternoon, then that could potentially mean that you would be staying the night, just going home prior to that 23 hours of your surgical time. So what to expect on the day of surgery? That pre-op phone call is going to give you arrival time. That arrival time, you do not have to arrive any sooner than that given time. So if it's 5 o'clock, you can arrive at 5 o'clock. You don't have to arrive 15, 30 minutes before that. Currently, we do not have valet services available at this time at either the University Hospital or the Missouri Orthopedic Institute. So our check-in location for the Missouri Orthopedic Institute, we know that there are patients that are not all coming here at the Missouri Orthopedic Institute to have surgery. And so we'll also go over the university entrance as well. But if you are having surgery at the Missouri Orthopedic Institute, check-in is going to occur on the first floor. So you will arrive into our building on the second floor main entrance. And once you enter the building, there are the blue elevators that you'll take those straight down to the first floor. Once you exit the elevators on the first floor, you'll be at the check-in for surgery. So you're exactly where you need to be, and that's the waiting room for pre-op. Now at the University Hospital, check-in is going to also occur on the first floor. You can park anywhere in that parking structure attached to the University Hospital, and you'll just want to make sure you come down to the first floor of the hospital, and you'll have centralized scheduling right on that main floor. So once you arrive in there, they'll have you check in. However, their OR waiting room is located in a different location, and they will definitely direct you in that direction once you check in on the main floor. So once you arrive and are checked in for surgery, the patient will be taken to the pre-op room for surgery. We do at this time have an update board that is located in both of our waiting rooms that each patient will be given a unique number that identifies them on that board. For patient confidentiality, we do not want to put their names on that board. And so that unique number will be on the board, and as time progresses, they will give you updates of what's going on with your patient in the OR. So they're just generic terms, kind of like if you are, surgery has started, things are going well, we will be done with surgery in an hour, physician will be out to speak to you soon. So very generic updates, but at least you will know how things are progressing in the OR room. After surgery, the patients are then taken to the recovery room. The recovery room is, generally speaking, about an hour-long process. Typically speaking, we do not allow family members back there because it's one open space, and to protect patient confidentiality, we try to avoid any visitors in the recovery room phase, which is that initial 1 hour right after surgery. And that 1 hour is going to be dependent on how well the patient is doing at the time. So at that point, that's when IV fluids are going to be given. We're also going to make sure that any complications after surgery, if you're having nausea, vomiting, any pain issues, will be addressed at that point, just to make sure that you're stabilized prior to taking you to your next step of recovery, if that means going home or going to the inpatient unit. We've already talked about length of stay, and I had mentioned that the majority of our patients now are trending towards that same day surgery where you're discharged prior to 23 hours of your surgical time, and some of our patients, they stay up to about 2 nights. Length of stay is going to vary for each patient, and it's going to be determined by several factors. It really is going to be determined by how safe you are to be discharged to home on your own, how well you're doing with physical therapy, how well we're managing your pain, and then of course insurance plays a big part in the length of stay as well. Again, we know that pain is a very anxiety inducing issue after surgery, and so we do talk about this a lot. Pain management after surgery, what I usually want to tell patients is that our biggest goal really is to mobilize you post-op day 0 after surgery. So that's day of surgery. Our goal is to get you up and moving out of bed. So that's why we use pain medications, is to make sure we can do that both comfortably but also very safely. So our first course of action when it comes to medication, or pain medication, is usually oral medications. Reason for that is because those oral medications are what you're going to be going home on, and we want to make sure that that is the proper balance for you to manage your pain at home, because you'll be doing that on your own. Obviously, we will have access to IV pain medications in the hospital, and you know, for those times initially when we get you out of bed and maybe you might have overextended yourself on your first physical therapy session, and you've already had pain medications and you thought, oh, I might have done a little bit too much and my pain medications aren't covering it. So absolutely, we have access to those medications to help you with those breakthrough periods. But the majority of the time, what we want to do is be able to find that right recipe for you to go home on with oral medications. Now, what we want you to understand really out of this whole slide is the fact that this is not just determined by your physician and your nursing staff. We want you to have as much input in this as well. So you let us know how things are going and how you feel your pain is being managed, and we will try to manipulate that schedule and the medications to best suit you. You know, clearly we can't just over-medicate you, take away all your pain, and expect that you're going to be safe to move and get up and move around safely. So we certainly can't do that, but we have to find that right balance of both safety and then also comfort. So our goal is to get you moving. We definitely have our patients, usually in most situations, they're going to be up mobilized on the day of surgery. And now, when I say this, I don't want you to get scared and think that we're going to walk you 3 blocks on your very first time getting up. Really just simply moving in any situation, such as getting out of bed and just sitting up to the edge of bed, is considered moving. What we want you to know is that we do want you up and moving as soon as possible, but we definitely don't want you doing that on your own. So for that first few times until physical therapy tells you you're doing just fine to be able to get up on your own, you will be calling for assistance anytime you get up out of bed. What we also want you to know is the majority of our patients do not need any assistive devices to help them get moving after surgery. So obviously, for those patients who have already been walking with walkers and canes with assistance, may need that after surgery. But typically speaking, for those patients who have not or weren't using assistive devices for walking, there may not be a need for that. However, what I want you to know is that if that need is needed, if we find out and assess that there's a need for some sort of adaptive equipment to help with mobilization, our physical therapists will help you with that. So once we assess that and we determine that you need that, we can certainly get that equipment for you. There are other equipment out there that helps with activities of daily living. So simply things like when I told you to just take a day in the life of how easy things are for you in a daily log, maybe you took notice that, man, it's really hard for me to get my shoes and socks on and reaching my feet. So that's when those notes come into play, is right here. So if you have noticed that those are needs that you had prior to surgery, then more than likely you might have those needs again after surgery. And then we probably have adaptive equipment that could help you with those kind of activities. So just make sure that you let your physical therapy team know about those issues that you had, and then we can certainly find something to kind of help address those issues when you get home. As far as discharge goes, I'm not going to go into too much detail about discharge summary. Just simply, you will have a paper form that will have all of your appointment times, your do's and don'ts after surgery, all of your follow-up appointments, dressing care, incision care, and when you're able to return to normal activities. Those will all be printed on a discharge form for you to take home to your family members so they also know how to care for you once you get home. What I really want to mention here is we do have prescription services here at the University Hospital and at the Missouri Orthopedic Institute. So if you are being discharged and you want to fill your prescriptions with us prior to leaving, we have a bedside pharmacy program, basically stating that if you want to fill prescriptions, what you will do is tell your nursing team that you would like to fill your prescriptions prior to leaving. We would then take those prescriptions down to pharmacy. They would then at that point figure out what kind of copays you have and then give that information over to nursing. You would then provide form of payment, and once you pay, they bring that prescription up to you without you ever having to leave or your family ever having to leave the bedside. It's a great program, and the reason why is because getting patients home after discharge is a very stressful event for family members, and having to get the patient home and going to get prescriptions dropped off and then having to leave again to pick up prescriptions, it's very stressful. And so if we can eliminate that stress by allowing you to get your prescriptions here with us, that's an awesome service for our patients and family members. Now, a lot of the concern about getting those prescriptions filled through us is that we understand that a lot of our patients are coming in from out of town. And so the concern is, if you have refills, do you have to get them here through us all the time? And the answer is no. Number one, we don't give refills on any of our prescriptions. And what I mean by that is not that you can't get refills, but our initial prescriptions will never contain refills. If you need refills on anything, you will have to contact your surgical team. And at that point, once they determine that they want to give you a refill, they will e-script that to a pharmacy closer to your hometown. So you will never have to come through us to pick up prescriptions if you don't want to. And so just to be aware of that service for our patients, so that way they know that that's something that can eliminate a little bit of stress for them upon discharge. So post-operative physical therapy, none of our surgeons are going to recommend physical therapy before 6 weeks. So in that first 6 weeks, what they want you to do is really just to concentrate on being able to increase distances on walking and activities of daily living. So really no physical therapy, but really just to increase those normal activities that you were doing. So where physical therapy comes into play in that after that 6 weeks is if you, in about 6 weeks you notice that maybe you don't feel like you are progressing as much as you would like to be in your distance. Maybe your distance isn't increasing. Maybe you've only walked half a block at 2 weeks and you're still at half a block at 6 weeks without having discomfort, a fair amount of discomfort. If you feel like you're still having a fair amount of difficulty getting in and out of a bed, maybe getting in and out of a chair at 6 weeks, if you have any of those kind of issues, at that point, you will have a follow-up appointment with your surgeon in and around that 6 week time frame. If you're noticing that you're not progressing as well as you would like to be at that time, I would always recommend for patients to then discuss that with their surgeons. They will typically never recommend to have surgery or to have physical therapy before that 6 weeks period of time, but they seldom ever hesitate writing a prescription after that 6 weeks. If they feel like you're not progressing as well, then they'd be more than happy to do that. So you would just have to be able to verbalize that concern with your physician and bring that up at your 6 week appointment. So that concludes Spine Camp here. I appreciate your time. We do have a way for you to submit any questions if you have any further questions through the Health Connect online portal if you have that. And then also feel free to call 573-884-BACK or 573-884-2225 You can certainly talk to our nurse triage line, or if you would like to be connected with your surgical team, if you have direct questions for your physicians, feel free to submit those. Thank you very much.